Welcome to Emergency Insights. I'm James Carter. Today, we're joined by Dr. Emily Wang, a leading expert in trauma and resuscitation. We're going to be talking about a subtle but dangerous complication in massive transfusion protocols, hypocalcemia. Dr. Wang, thanks for joining us.
It's a pleasure to be here, James. This is a topic I feel very strongly about, and I'm glad we can bring it to the forefront.
Dr. Wang, for our listeners, what exactly is happening on a physiological level when we give a patient a massive blood transfusion that puts them at risk for hypocalcemia?
That's an excellent question, James. The key culprits here is citrate. Citrate is an anticoagulant added to blood products to prevent them from clotting in the bag. When we administer these blood products rapidly, the patient's liver can't metabolize the citrate quickly enough. This excess citrate then acts as a chelating agent, meaning it binds to or grabs onto the patient's free ionized calcium. Since it's the ionized calcium that's physiologically active, this binding effectively lowers their functional calcium level, leading to hypocalcemia.
And why is that a major concern? Why should a clinician be so focused on calcium levels during a massive hemorrhage?
Calcium is critical for three main reasons, especially in a trauma setting. The first is cardiac function. A low ionized calcium level can cause myocardial depression, leading to decreased contractility and lower blood pressure, which is the last thing you need in a hemorrhaging patient. The second reason is coagulation. Calcium is a vital cofactor in the coagulation cascade. Without adequate calcium, the patient's ability to form a clot is impaired, exacerbating their bleeding. And finally, low calcium can increase the risk of cardiac arrhythmias. In a critically ill patient, this can be the final insult that leads to a catastrophic outcome.
A practical tip in our daily practice is to give calcium after 4 units of blood. Could you elaborate on this? Is there a standard protocol or a rule of thumb our listeners should follow?
A 4 units rule is a widely adopted and pragmatic approach. It's a proactive measure because in the chaos of a massive transfusion, you don't have time to wait for lab results to confirm hypocalcemia. A good rule of thumb is to give 2 to 3 grams of calcium gluconate for every 4 units of red blood cells administered. Some protocols also suggest giving it after every 3 units of packed RBCs, particularly in pediatric patients or those with liver dysfunction. The key is to be proactive. Waiting for clinical signs like arrhythmias or a low lab value means you're already behind.
Calcium gluconate is the recommended choice. Why not calcium chloride?
Both calcium gluconate and calcium chloride can be used, but calcium gluconate is generally preferred in most settings for a few reasons. First, calcium gluconate is less irritating to peripheral veins, reducing the risk of tissue necrosis if extravasation occurs. While it has a slightly lower concentration of elemental calcium compared to calcium chloride, it's safer to give through a peripheral IV. Calcium chloride is more potent and is often reserved for central line administration or specific circumstances where a rapid high dose is needed. For routine prophylaxis during massive transfusion, calcium gluconate is the safer and more common choice.
Dr. Wang, thank you for sharing your expertise on this crucial topic. Your insights will undoubtedly help our listeners provide better care for their most critically ill patients. That's all the time we have for today. Thank you for listening to Emergency Insights.